So um, thank you everybody for the opportunity to present today. I gave a version of this talk at the American College of Surgeons a couple of years ago, and I have updated it and reformed it to include my residency experience. So it's the Abington edition. I have no disclosures. So the story begins with a young girl named Libby Zion, who was a college student at the time. She was admitted to a hospital essentially with a panic attack, and she was admitted there for 3 days. She had an extensive psychiatric history, so admission for her was not rare, but over the course of the next 3 days that she was admitted there, she was seen by 3 different residents, no attending, and ultimately was given medications that were incorrect and was misdiagnosed, and she died of a heart attack. Her dad was a very influential journalist and investigated why his daughter had died and found out that there all of these deficiencies existed, and there was very little supervision, and the overworked and under-supervised resident was kind of a thing. So he started a reform process that ultimately led to a domino effect that is now what we know as our 80-hour work week. So the ACGME mandates that we only work 80 hours per week, and that's averaged over a 4-week period, and that includes everything that we do: in-house clinical call, educational activities, moonlighting, work done from home. So I want to propose some math for us. So 80 hours a week for 48 weeks a year, assuming we get a few weeks off for vacation, times 5 years. So in surgical residency, we have a total of 19,200 hours. And I want you all to remember that number, please. So the ACGME thinks that 80 hours are enough for us to become competent surgical surgeons. And I'm here today to propose that it's not about 80 hours that are enough, it's 80 good hours that are enough. So in order to understand how to become a surgeon, we must first understand what it takes to be an expert, because we all strive in any profession to become experts in that field. We start off as interns knowing very little to nothing about what we're doing, kind of running around, watching other people, trying to fit in, ordering our first Tylenol, and just the anxiety that comes with it. And then through a process of seeing, doing the seeing, updating our mental model, and doing again, we become competent, and then we become effective. And by the end of residency, we really can adapt. We know how to vary our performance based on different situations that we're in and apply principles. And then finally, we become experts when we're attendings and we finished our training. And we really have this automized capability to just know the solution. And at that point, we reach this pinnacle of expertise where we can really teach others. And that's ultimately the goal. So I propose that there are 3 obligate ingredients to this. The first is deliberate practice. Deliberate practice is a concept that's been around for a pretty long time. It's a principle in psychology in which people sit down and apply themselves to a art form or a practice, and in isolation review skills and techniques and practice that in order to become experts. Erik Erikson was a cognitive psychologist that performed an experiment in Austria. He asked a series of violinists to record how many hours they deliberately practiced over the span of 20 years. If you look at this graph, essentially by age 20, the people in society that were deemed the best, notified by the square boxes, and professionals by the triangular boxes, had practiced a total of 10,000 hours. This 10,000 hour rule became very popular with Malcolm Gladwell's book Outliers, in which he gave many examples of people in society that had achieved expertise in their fields by practicing around 10,000 hours. So here we have the Beatles. Between 1962 and 1964, they traveled all throughout Germany and booked any venue they could and just practiced together day in, day out. And by 1964, they had released their first album. And by the end of that year, they became successful globally and became a hit. And they had practiced 10,000 hours. So let's go back to our math: 80 hours a week, 48 weeks a year, 5 years. 19,200 hours. So that's almost twice as long. The next ingredient is the creation and maintenance of a wealthy experience bank. There's an imperative as a surgical resident to be an autodidactic learner. No surgeon ever achieves expertise without driving his or her own training. The purpose of repeating operations should be to just see the planes around a specific anatomy. And more importantly, it's actually to know what's lurking beyond what you can see, what's behind that tissue plane, what could get you into trouble. Residents that are dedicated to this mentality understand that in surgery, every job is a custom job. There's no such thing as an easy appendectomy. There's no such thing as an easy chest tube, central line, anything. This is where an experience bank of good hours, bad hours, and bad hours that you actively turn into good hours is key. So I actually first experienced this when I went to CHOP during my second year. It was a really cool time for me because it was the first time that I really went into the operating room kind of nonstop. I was double scrubbing cases with these world-renowned surgeons operating on a patient population that I had never really considered operating on before. I was very nervous. When I was alone, I remember scrubbing a laparoscopic appendectomy in a 10-year-old. And I was just, holding these instruments and gripping them with dear life, worried about, harming a child. I wasn't used to the anatomy. I wasn't in kind of the field of view was unique to me. So the surgeon at the time, he kind of looked at me, observed how anxious I was and told me, Lily, relax your shoulders. What is your left hand doing here? Bring lefty into the game. Bring lefty into the game. That sentence was a milestone in my surgical training, and it really changed everything. That what I thought initially was a bad hour became a good hour. So I brought this mantra back home. From then on, almost every time I would scrub a case, I would write down specifics of what that attending liked, how they liked to prep, what instruments they used, where they made their incisions. And this is very different from attending to attending. And I would write this down and I would take a picture, and I have all the pictures in my phone actually. How does Dr. Panetta stick that femoral artery the right way every single time? Why does Dr. Sullivan use that petty point? Dr. Pack, and when he closes his incisions in the thyroid, he tells you to take small bites in the corner. So you can apply that principle anytime you're closing with monocryl and the incision comes together nicely. Every attending runs through your head, as long as you remember to take bad hours and turn them into good hours. And then finally, we have heroic moments. Now, this is a little bit more abstract because heroic moments are those composed of those that engender action. It's the ability to intervene based on the lived knowledge of the correctness of an intervention. So imagine the trauma bay at night, and you're the chief resident on call, and you're left alone only with your own judgment. When the patient comes in, you're the one that makes the call to intubate, to crack the chest, to call a code. The decision is yours and yours only. And it's only, it is an execution of the function only of the skill that you exert. And whether an attending is there to guide you doesn't matter. It's really a moment when you turn yourself away from yourself and you turn your will towards the patient. And in that time, in that moment, your growth as a surgical resident thrusts way beyond its envelope. You have to remember that, good judgment comes from bad judgment, and bad judgment comes from inexperience. My PGY 1 year, I kind of had heroic moments that I observed in my co-residents. There was a lot that I learned from their stories and the sacrifices they had to make, and the heroic moments that they had encountered in their lives up to being PGY 1s, that I found that, kind of changed me moving forward and gave me perspective. PGY 2 year, self-explanatory, in the ICU. There are so many times, and all of us have probably been there if we've rotated in the ICU, where we've had that patient that, is Brady, 40, 30, 20, the code card's right outside the room. In those moments, you channel in your inner Dr. Butler, your inner Dr. Ushak, and you think to yourself, it's time for me to channel all the information I have and save this patient. It's like starting a race. Those are heroic moments that change you. PGY 3 year, you're trauma chief. So that's definitely a moment where you get to exercise your skill, and you have many of heroic moments that help you grow. Particularly for me, uniquely, COVID-19 happened, and we were called upon to take care of COVID patients. And there were a lot of moments for me that I felt that I was able to help people, but there were also plenty of moments that I was not able to help people. And all the time I had to just keep reminding myself, good judgment comes from bad judgment, and bad judgment comes from inexperience. PGY 4 year, as night float chief, the interesting piece of it was that I served as the kind of queen of the hospital in a certain way, in the surgical sense. And the attendings really had a lot of trust in me. When I would make a decision, they would kind of go with it. They were half asleep at home, and you would call them and they just had to go off of what you said. And so it was a lot of burden on your shoulders. And so those moments I had to encounter where I made the call to take the patient to the operating room were stressful. However, for the most part, when you had success and you were able to help the patient, those heroic moments helped you grow. And all of that culminated in my PGY 5 year. And I look forward to be able to continue this in my fellowship. So this graph here is kind of a summation of my talk. On the x-axis, you have time, and on the y-axis, you have competence. And I've divided it up into your phase in residency and then your phase as an attending. And as you see here, this is kind of a different take on the classic S-shaped curve, because the slope is different depending on the type of ingredient that you practice. So here, initially, when you practice deliberate practice, the slope is pretty predictable. It rises slowly but constantly over time, and you become competent. And then you have this jagged rise when you have your experience, when you're building your experience bank. And if you zoom in on the little ridges, you see that it's composed of good hours that help to improve your competence, and bad hours that don't necessarily do that. But eventually, over time, your competence rises. And then finally, you have heroic moments, which show a huge jump in your competence over a very short amount of time. And that's exactly what the heroic moments are meant to represent. And then at the end of residency, or at the end of your training, you become an attending. And when you're an attending, you actually still continue to have a rise in competence over time, but the slope is much more predictable, and it never fails to rise. Even when you're far into becoming an attending, there's always stuff to learn. And so I want to leave you with the message that in surgery, training is not something that is given. It must be taken. In that way, only the pawn becomes the queen. And in that way, 80 good hours are enough anywhere. Thank you very much.